Thank you very much. I can't tell you how exciting it is to stand in front of a real audience, of real people. I seem to have spent months talking to a screen to do talks, feeling progressively getting more comfortable with it, but really at the beginning feeling like, what the hell am I doing? So this is really lovely. So for those of you who haven't heard of Getting It Right First Time and maybe don't do critical care, this is a plug. My report has finally been published, and it was NHS-EI, for reasons unclear to me, have put it on that future NHS platform. So if you go to Getting It Right First Time, or Get It Right First Time, Google it, and then click on the critical care report, it will take you to basically a login to the future NHS thing. I don't know whether that's intended to put people off or what. It probably does. Given my usual way of dealing with these things, the report is now online and downloadable from both the Faculty of Intensive Care Medicine website and also the Intensive Care Society. So if you want to have a look at it, it's there and you don't have to faff around with the other thing. So what was GIRFed about? I don't know how many of you have been privileged, as you might say, to sit in a GIRF deep dive in any specialty, not necessarily critical care. It started in orthopaedics. I'm definitely not an orthopaedic surgeon, but Tim Briggs could not be anything else. And it's to look at how different departments are, how they do things differently, why they do things differently. Could they do things better? Could they do things more efficiently? And let's be honest, could they save money by doing that? So the kind of things you can look at in joint replacements are, can you get through 4 big joints in a day? If you do redos, do you do lots of them so you're good at it? Or do you do 1 or 2 a year where the evidence suggests that you won't be good at it, so you should probably stop? Only an orthopaedic surgeon could tell another orthopaedic surgeon to do that. So, shown to be successful in orthopaedics, it then gets spread out to many other specialties, mostly surgical to start with, and then into the medical sphere and to anaesthetics and perioperative medicine and critical care. So, critical care is really different. I can't count joint replacements. What do I count? Well, there is quite a lot of information out there, and we pulled together what we could, came from ICNARC and NELA and HES and anywhere we could find it, bundled it together, see what messages we could pull out of it, and then send the reports to a hospital and go and sit down in a department and talk about it. And that is one of the most fascinating things that I've been able to do in my career, to sit down with the intensivists, the nurses, the physios, the dietitians, the pharmacists, the chief executive, the finance director, the medical director, all in a room for 2 hours and talk about what your critical care looks like. And that engagement from the entire team is really fascinating. Sometimes you sit there and everybody is clearly on message and they're getting support, and other times you see the sideways glance from the chief executive that says, you lot better shut up now because I don't. Just fascinating to see how it all works. So you've rapidly learned, and I thought that what critical care I do is what critical care is. And I go to find it looks very different in different places. People think differently, they work differently. From the patient's point of view, there is not equity of access. You do not get the same deal in every hospital in the country, and that worries me. What happens is very much determined by the geography, the money, the staff, and the way you build your unit and hospital culture based on what you've got. Talk about that a bit more later. And there are most definitely the haves and the have-nots. I think my hospital's got most of the kind of things that I would like an intensive care unit to have. It's not perfect, But there are other places where my heart almost bleeds for what people are trying to do without the staff, without the beds, without the support. So I'm an intensivist. I'd like to think of myself with my knickers on outside my trousers, driving around in something like this and responding to deteriorating patients. It's exciting, it's fun, isn't it? And it's what we want to do. Do we have the data to show us what actually happens? So, this is a funnel plot, and along the bottom, I don't think I've got a pointer, never mind. So, along the bottom is the number of admissions that you get from the ward each year, and up the side is percentages. And it's the number of patients coming to your unit who already have 4 organ failures before they hit your door. And you can see that there is a huge variety. Most places are within those tram lines of the funnel, but there's a few kind of dangling outside, and this particular unit that's got the blue spot, he's kind of getting perilously close to being a bit outside it. Would you want to be a patient there? This is another way of looking at it. This is taking ordinary hospitals, general hospitals, we've taken all the specialist ones out of this. What proportion of patients who were admitted to the hospital get admitted to critical care? And there's about a 4-fold difference. Now, is that because there is a 4-fold difference in patients getting sick in different hospitals, or because there's a 4-fold difference in access to critical care because the resource is not there to supply it? We looked at specific disease processes. The respiratory doctors still think that critical care doesn't like patients with COPD. So this is one of those culture things. Do you believe that a patient with that disease process is likely to get better from their stay? Or do you say, sorry, I'm not going to take them, I'm not going to ventilate them because I don't think it will work? And the answer is those opinions are very different everywhere. I know that I make my own snap judgments at times. Is critical care worth it? So one of the things that ICNARC does is it takes all of the data about the patients that come into the unit and works out whether across the whole country, a standardised mortality ratio of 1. So if you're doing better than 1, less than 1, you're doing better. If you're doing worse, your SMR is greater than 1. If we use the same fiddle factor that corrects it over time, then over the 10 years that this data shows, the outcomes from critical care are better. So we are doing a good job, I hope, I think, but it's not necessarily the same job everywhere. This looks at the bed days. At the bottom, the dark purpley bits, the bluey bits, are level 3 bed days. That's multi-organ failure, 1 whole nurse to look after you. The bluey bits are high dependency, level 2, half a nurse to look after you. What's really kind of obvious over 10 years is that the level 3 bed days in England haven't really increased. But our population's grown, our expectations have grown, our population's aged. You might expect that we were seeing more of that, but we're not. What we are seeing is that growth in level 2 beds. I can't prove this, and Manu's probably going to show much better data than me. But seeing patients as they're slip sliding before they hit rock bottom and bringing them to critical care when all they need is high dependency care and trying to avert that deterioration probably is worth doing. It's cheaper, much cheaper to be in HDU than it is to have multi-organ failure and intensive care. It's much nicer for the patient, and your outcomes are likely to be better down the line. A level 3 stay in critical care is very bad for you. So how do we collect those patients? Now, many of you will have been involved in outreach teams or hospital at night or something like that. And I was quite surprised to find how many places don't actually have that much in the way of outreach. So about 4 in 10 places have got 24/7, and another 4 in 10, no, 3, 4 in 10 have got daytime cover, but not 24 hours. But about 1 in 6 places doesn't have an outreach service at all. Now, for me, outreach embeds critical care within the hospital. It's our kind of eyes and feelers that are out there working out what's happening in the place and supporting everybody. One of the things that we don't know is what the right dose of intensive care is. If you go to Germany, there's about 10 times as many intensive care beds there as there are here. Is that the right amount? Is what we've got the right amount? I think if you're in a department trying to work out roughly how many beds you should have, looking at your bed days and finding that you've got more level 3 bed days than level 2 bed days probably means that you have to wait for patients to get sick before they can get in. And that you should probably be looking at about 50-50 so that you can admit people quick enough. The new kid on the block is enhanced care, and you'll probably have heard about that. That's for patients post-operatively who need more monitoring, who need more nursing input. That's the whole magic of critical care as far as I'm concerned, what other people do to them, not what I do. Or respiratory care units where patients can get NIV. All of those beds need to be in the mix. And I know that Ramani, who's the National Clinical Director for Critical Care, is trying to push the case that we should be going for about 10 beds per 100,000 population. And at the moment, wherever you, in various places, it's somewhere like kind of 6 to 8. So it is an increase. We can only increase if we can find more staff, of course. So the culture in a place, who to admit and when to admit them. And we all have our prejudices, as I said earlier. I remember sitting in the office getting the handover from the night team. And one of the patients that they presented, they said, this gentleman is 95 and he had surgery for gastric cancer. He came to HDU for 2 days post-op, went back to the ward and has now been readmitted to HDU. And I'm kind of banging my head on the desk going, what are we doing to this poor man? This just, my prejudices said, he's old, he must be frail, he's had a big operation, he's had a good kicking. This is going to kill him. And then I go in the ward and the patient's sitting there, completely bolt upright in bed, asking me when he can get back on his bicycle. Now, he did confess that, in fact, he'd given up going out on the roads on his bike, but he was spending 30 minutes a day on his exercise bike before he came into hospital to get himself fit enough for his operation. And indeed, he got out of high dependency and the hospital. But we are all human, and we tailor our views on our what's happened before, what we've seen before. And also, if you only have 6 beds, you can only put 6 patients in them. If you've got 20 beds, it gives you a lot more scope. We tailor our opinion on what we've got. And that becomes normal for us. We think that that's what everybody else does. And it's quite fascinating. Critical care's a team. We cannot do it without all of these people. How many of you have tried to bang in a business case to get more beds, more nurses, more AHPs, and it's been filed on the too difficult, can't afford it pile? The asteroid is real. It is coming for us, and we cannot keep saying we can't afford it, because some of these things are actually cheaper and better than just letting the asteroid hit us. So this is my favourite one. Having a critical care pharmacist, specialist critical care pharmacist, is actually cheaper than not having one. So go back and convince your finance directors that this is the case. Because what they do with drugs and preventing us getting sued and having bog-ups and all sorts of other things is worth its weight in gold dust. So you absolutely need one of these. Physio. Like, why would patients only need physiotherapy 5 days a week? And why would they not have access to rehabilitation? They're people who need to be supported. And our physios are so useful at helping us manage those long-term patients and working with the patient and the family as to how we get patients through this. There's much more to critical care than dead or alive. But our main data collecting system, ICNOC, that's its endpoint. Did the patients leave you from the intensive care unit, dead or alive? Did they leave the hospital, dead or alive? And that system has been great for us. It's shown us what we do. It's helped us take part in research projects. It hasn't enabled us to develop the rehabilitation and follow-up services that our patients need, because we don't have the data to bang on somebody's desk and say, this is what we could and should be doing for our patients. So if you have a stroke, there is a funding stream to get into to get rehabilitation. It may not be perfect, but it's better than nothing. If you've had a month in critical care, you're on your own, Chuck. Off you go. Because it's very difficult to access that. What happens to our patients afterwards, most of us don't know. So this is taking ICNOC data, marrying it up with HES data. HES data is not perfect, but never mind. It normally knows when someone's come back into hospital. So this is a patient admitted to critical care that's readmitted to any hospital in England within 1 month, 3 months, or a year. And that is a lot of people. By 1 year, 50% of people have been readmitted to hospital. That is not cheap. That is not good for people. Some of it is avoidable, but maybe some of it isn't. And we also don't know whether our patients die when they leave us. This is at 3 months. The lines for other hospitals look the same. In all of these graphs, each vertical line is an individual hospital. So up to 30% of patients will be dead within 3 months after a critical care stay. We spent all that money. We made them suffer. We made their relatives suffer. Can we change this? Can we use that information to help us reform that culture about which patients come in? I don't know, but we need to start using that data better. We need to find it, we need to collect it, and we need to work with it. So, what do I think critical care needs to do to get it right first time? I think early intervention is so important. Grabbing a patient when they start down the slippery slope before they hit the buffers at the bottom, definitely. Outreach are a big part in helping us do that. We need more beds. Nobody ever wants to talk about more resource, but if it helps us deliver the rest of the hospital service better, you cannot have a hospital with a front door without a critical care area to support that. It just doesn't work. You can't transport all of those patients to a big centre. There's too many of them. Too many units do not have the AHPs that they need to do the job properly. And as for recruiting nurses, well, good luck with that. We need follow-up data, we need rehabilitation services. So, are there any messages that, not just for critical care? It was a bit of an eye-opener for me, because I thought, I did the job. I did critical care. But if that extends everywhere, and I did go on some other visits with Tim Briggs to orthopaedic places, and you go to somewhere very affluent, and the surgeons are all in their three-piece suits with their nice tie, all done up, and they've got the resource, they've got the theatres, they've got all the kit in theatres, they can get the work done, they live in an affluent area, they can recruit staff, and it just hums. You go 50 miles down the road to somewhere that is much less affluent, doesn't have the money. The surgeons all look as if they're knackered because not only are they trying to operate, but they're trying to find the staff to assist them in theatre. All of those things, it just doesn't work. And we need to kind of look at those bits. Why do things not work and how do we fix them? And don't just assume that what we're doing can be taken somewhere else. We need to sort out equity of access to all of our services, not just critical care. We all need to think about our culture and how we build it and where it comes from. And I'd love to do something about the haves and the have-nots. I'm really pleased that I think I'm in a have unit, but I wouldn't want to be poorly in some of the have-nots. Thank you very much.